Hello, I'm Dr. John Kruse, and welcome to this morning's we're getting notices that the connection's really bad. So hopefully we'll continue to be able to hear me. If I disappear, put a note in the comments because sometimes I don't always know when it's working or not. So the hour today is for my attempt to answer your questions regarding either the video I released last week or ADHD in general, or more broadly on mental health questions. To the extent you're willing, you can ask personal questions or more general philosophic questions or physiologic medical brain questions, whatever works for you. As usual, the answers I try to provide are for informational purposes only, so they are not specific recommendations since I don't have a doctor-patient relationship and haven't thoroughly evaluated any of you. And what else can I say? I think that's the general warnings framework. So the one I'll summarize the video and then jump into the content. So the video. Hello, thanks for those of you who stuck around. Sorry for the bad connection. Um, so I am completely dependent on Starlink here. I'm in rural Hawaii, and what else can I say? Oh, Starlink has been particularly bad the last 2, 3 weeks. Some people say that's because Elon Musk is sending satellites to different parts of world conflict to, I don't know, promote peace, war, whatever he's up to. So last, the release this week was on cortisol and ADHD. So cortisol is released in a genuine circadian pattern. So it starts rising before you wake up to get your body prepared for the day. It's not just responding to waking up. So peaks within the first hour of waking up and then is dropping throughout the day. By midday, its levels are anywhere from a half to only a quarter of what they were at the peak, continues declining during the afternoon, and then is at very low levels throughout the night until just within the hour before waking up the next day. And on top of that circadian daily pattern of release, the adrenal cortex also responds to stress by releasing a burst of cortisol. Those bursts are about as high as the morning peak is, so they're not dramatically higher or significantly lower. Um, and in so and cortisol in the body has effects on the immune system, dampening down aspects of it, but not shutting it down or off completely. It also is extremely important for glucose metabolism, so it helps your body make more glucose available to particularly muscle and fat cells and get it into muscle and fat cells. And it also has effects on the brain with notable cortisol receptors in the hippocampus, um, involved in memory, and in the amygdala involved in mood regulation. So a number of mental health conditions are associated with aberrant cortisol patterns of release. And this is an overgeneralization, but in depression in general, cortisol levels tend to be higher than normal throughout the day, and yet responses to stress are blunted or short. And in contrast, in PTSD, again, these are caricatures or dichotomizing. PTSD, the levels are lower throughout the circadian cycle, and there is a more robust, more dramatic response to stress. And in general, meta-analyses have shown that with ADHD, there is a somewhat of a tendency towards a more PTSD-like pattern, but that hides that there are many individuals with more depression-like patterns, some with normal-like patterns, and that the growing evidence is that cortisol release in ADHD is more associated with co-occurring conditions rather than the ADHD itself. Stimulant medications do result in some cortisol release, and I can probably stop there unless there's specific questions on cortisol and ADHD. So, hello, Dennis. Dennis asks, is it true that stimulants work better when combined with protein because protein supports the synthesis of neurotransmitters? So, yes, the tyrosine in protein, well, yes and no. So, the tyrosine in proteins is a precursor for making um, norepinephrine and epinephrine. The tryptophan and so tryptophan and tyrosine are both amino acids abundant in proteins, and digesting proteins releases amino acids. It does allow, it makes more of one of the basic building blocks of these neurotransmitters available, but one is that there is extremely little evidence to suggest that most individuals with ADHD or taking stimulants actually have a problem in the synthesis of neurotransmitters. So if you don't have a problem there to begin with, providing more of the raw ingredient isn't necessarily going to do much good or help. So I would say yes, if in the context you are deficient in synthesizing or making neurotransmitters, some protein can help. And again, the stimulants are mostly preventing the reuptake of neurotransmitters, and then particularly amphetamines causing an extra pulse of release of neurotransmitters, specifically dopamine and norepinephrine. But again, there's little evidence that most people are failing to make or manufacture enough of those neurotransmitters. So my experience with most patients is that having breakfast, having some small amount of protein and complex carbohydrates seems to help their functioning. Um, whether that is directly because of making more neurotransmitters or not, I'd say is a step that hasn't been documented. So, hello, Dylan. Yes, so I did do a little reading, not a deep dive into cerebrolysin. So, cerebrolysin is a combination of neuropeptides harvested from pigs. And there is some pretty good evidence in individuals with traumatic brain injury that delivering this, usually in an IV, cerebrolysin, is measurably correlated with better recovery from traumatic brain injury. Um, Again, I didn't do a deep dive, but it's less clear. So clearly, short-term acute use, the sooner after the traumatic brain injury, the bigger the impact was found. That gives us less information as to how helpful it might be for people whose trauma or other conditions that they're trying to treat are further in the past. So um, I don't know anything, no clear-cut problems with using it, but how helpful it's going to be, I think, is less clear in a host of other conditions it's being used for. So Acetylcholine 2026 asked, what jobs are good for people with autism? So one thing I would say is that separate from the category or the list or or condition or the label you're putting in, each of us are still individuals, and I think finding a good fit between the individual and the job is the most important feature. More often I get asked this question regarding ADHD, and I sort of give the same answer. And particularly with ADHD, what's interesting, people with ADHD are motivated by what's interesting rather than by what's important. Um, so finding a job that's interesting to you and where the workplace conditions fit with who you are. I mean, with social interactions being a challenge for many people with autism, most of them or many of them would prefer a job where the social interactions are fairly clearly defined and or limited. But that's still, particularly in our fragmented, getting away from the workplace world, that leaves a lot of options. So I'll leave it to that. Um, Acetylcholine 2026 asks, how can I know if I have high cortisol or high adrenaline? So one of the nice things about cortisol is that it can be measured fairly accurately in saliva. So saliva does track pretty well with blood levels. Um, so your doctor could order either blood or saliva cortisol levels. My question is it going to tell you anything you don't already know anyway? So again, it's released when you're under a stress condition. And again, both cortisol and adrenaline, which is epinephrine and norepinephrine, are released together. The cortisol is made in the adrenal cortex, and the medulla, the middle of the adrenal gland, makes norepinephrine and epinephrine. I mean, if you are feeling revved up and jittery, that's a pretty good sign that your adrenaline levels are high. So I'd say often we like to have a concrete lab value or test to show what's going on, but I'd say psychological information as to how you're feeling and what's being processed is often just as good as neuroscientific or medical information. Um, so Dylan asks, what are my thoughts on Nardil, phenelzine? Do I see it as the gold standard for social anxiety avoidance behavior? I've tried nearly all meds without much success. So I'd say there's a little evidence that the MAO inhibitors such as Nardil may be particularly good for social anxiety and avoidance, but the hype or the claims around it, I'd say, are far more extensive than the data. There's not a lot of good head-to-head comparisons, and the head-to-head comparisons that are done, I mean, it's not clear whether the dosage was optimized for the comparison medications. So I know there are many clinicians claiming its benefits. I'd say certainly if you haven't had good responses to other agents, it may be effective. I mean, it's interesting, although the SSRIs, the serotonin reuptake inhibitors, are sort of the gold standard by many for anxiety, including social anxiety. There's good evidence that the old tricyclic clomipramine has even more potent serotonin reuptake action. Um, so for things like OCD, it seems to be more effective in some studies than what we call the SSRIs. So the other thing is there is still lots of individual variation, and we don't know what all the important factors are. So I think the claims for being a gold standard are overhyped, is how I would come down on it. But again, that doesn't rule out. I have seen a handful of individuals over the last 30 plus years who did do better with anxiety, and particularly social anxiety, with phenelzine. I'm trying to think of other MAOAs, one with selegiline patch. So Cody 6518 says, I've been a little stressed out with some drastic life changes and have not slept, going on day 5 now. Even when I've dozed off, my body shocks me back awake. Um, I'm I don't know if there's a follow-up or extension with that. I have a video on cyclic sighing. So when we're aroused, over revved up, we're in a state of sympathetic overdrive. I would practice both during the day if you're over aroused during the day and having trouble falling asleep and staying asleep. Every time you wake back up, I would try about 5 minutes or 20, 25 cycles of cyclic sighing. Um, it's a drastic life situation. An acute change is one of the few probably good indications for medications for helping with sleep. And again, the more revved up you are, the bigger the dose you may need at that time. Most of our sleep agents are more effective in the short term than they are in the longer term or ongoing basis. And I can say more, but I mean, the important thing to remember is that sleep deprivation is sort of a two-way street. It's both the product of many of our mental health conditions, ADHD, PTSD, depression, anxiety can all disrupt sleep, but having disrupted sleep then tends to make underlying mental health conditions worse or create mental health conditions that weren't there before. So getting a handle on sleeping better, I'd say the other thing to remember is your body and brain really do want you to sleep, and finding a way to work with them and remembering it's highly unlikely that in 5 days your capacity to sleep or your ability to sleep has really been obliterated or destroyed. It's just temporarily interrupted. So, so Dylan asks, how do I feel about at home or compounded pharmacy formulations like intranasal esketamine? His psychiatric naturopath or nurse practitioner, could be either, that recently prescribed it for me. But the FDA doesn't support compounded ketamine for PTSD. So there have been cases or extensive cases of individual, I mean, compounding pharmacies are only as good as the individual compounding pharmacy, whereas a brand name or even a generic formulation is something that's repeatedly inspected by the FDA. And so there have been certainly been cases of contamination and inaccurately or poorly compounded preparations, including specifically with intranasal esketamine, particularly intranasal route. I would be more worried about how clean and pure and good it is because there's a more direct potential passageways towards the brain rather than a pill you're just swallowing. Um, I mean, if you have a pharmacy that you trust explicitly, I'd say how most of us, what would be the basis of that trust? We're not doing pharmacologic assays or microbiology assays on the products from that company itself or on that compounding pharmacy. So trust is going to be based more on word of mouth and at that level. Um, I do have a video on ketamine itself. There's a whole lot of unresolved questions. I mean, one is that is S-ketamine better for depression than a racemic mixture of S and R ketamine? That's not completely clear. There are some differences between the two stereoisomers in laboratory situations, but that doesn't show clearly that one will be better as an antidepressant or not. I mean, sometimes compounded pharmacy medications are, I mean, it increases the availability. So when there were NPI1 agonist, Ozempic-like drug shortages, there were still compounding pharmacies who could get people the active ingredient. On the other hand, um, yeah, so that there can be advantages to them, but you're much more tied to the quality of the individual compounding pharmacist. So, so Ambi asks, does atomoxetine, which is a non-stimulant medication, impact cortisol release? I am not familiar with specific studies looking at cortisol release with atomoxetine, but I would be surprised if it didn't because its immediate action is norepinephrine reuptake. I mean, in response to a norepinephrine surge that's experienced by the body as a stress response, and that would or should or is likely to, at least in a certain dosage range, result in a cortisol response. So my understanding is that most non-stimulants as well as stimulants that are contributing to norepinephrine or dopamine release are likely to have some, at least mild, cortisol surge release. Um, Unshin O says they were wondering whether someone who's currently taking Vyvanse with adjunct therapy would be best in ameliorating cognitive function deficits, viloxazine or guanfacine. Um, so Vyvanse, which is a formulation of dextroamphetamine, they're wondering whether it should be combined with viloxazine, which is Qelbree, or guanfacine. I would say I don't think we have general markers yet. Even so, one specific question is: are there specific cognitive functions? Are there, is it impulse control or um, better working memory? If that's the goal, are you going to be better by augmenting with Qelbree versus guanfacine? So I don't think we're yet at the stage of having biomarkers or neuropsych markers for identifying what's a better next agent. So at least some of the mechanism of action of both Qelbree and guanfacine differ from that of Vyvanse. So to that extent, either of them are a logical um, potential adjunctive agent. The general concern are, yes, you're multiplying potential levels of interactions and complications and side effects. So one is to make only one change at a time. Two is to start low and observe what you're seeing. I'd say one important difference there is for most people, many of the benefits from viloxazine show up within the first few days, whereas with guanfacine, they're almost always slow and delayed on the order of 2, 3, 4 weeks. So just in terms of looking for when you would expect improvement. And the other thing I encourage people is to try to have semi-quantifiable goals. And I mean, if you know that 30 times a day you are forgetting what you walked into the next room for, and that drops down to just 10 times a day, that's a quantifiable approximation that you're seeing some improvement. So thanks, Max, for providing the link to the cyclic sighing video. Um, so Ambi asks, is it possible, safe to take atomoxetine and anti-anxiety? I'm assuming anti-anxiety medication, not anxiety-producing medication at the same time. Um, One is the question is, what are we talking about in terms of anxiety medication? So the experts pretty uniformly in the US and elsewhere proclaim that SSRIs are the first class or first choice anxiety medications. They do work slowly like they do for depression. And SSRIs with atomoxetine work well for many people. Many people more simply just go with an SNRI like duloxetine, which combines an SSRI and a S and an NRI, a norepinephrine reuptake, and a serotonin reuptake action together. Some people are more sensitive and need or want to titrate those two individually. If we're talking about benzodiazepines, the Valium, lithium, Xanax, Ativan, Klonopin drugs, most experts would say those are best used for a short-term acute anxiety bout, particularly one that's externally caused and we know will be ending with time. I mean, to some level, the anti-anxiety drugs are working against some of the norepinephrine boosting effects. So the benzodiazepines are working directly via GABA, but the GABA systems are shutting down some of the norepinephrine arousal systems. So to that extent, there may be interference with each other, and a less good fit, although I've certainly seen people in the short term who are on atomoxetine or a stimulant who benefited from a benzodiazepine. And thanks again, Max, for providing the link to the ketamine for ADHD link. Um, and thanks, Max, for being around and available and helpful here today in front of the scenes and usually behind the scenes, doing a lot of what helps my videos be more presentable. So Penny, and I can't read it, the gray part well without my glasses. Penny something says, my husband was on prednisone for 2 years to counteract side effects of Zytiga. I am not familiar with Zytiga. He was weaned off the prednisone. After a month without it, they did a cortisol test and it was extremely low. Now what? So prednisone is a cortisol-like drug, which does suppress cortisol manufactured by the adrenal glands. And part of the reason for always tapering off of prednisone is that it can suppress cortisol. And if you stop abruptly, then there can be a too much cortisol released and then being on it too long. So one is, for having been on that drug for 2 years, 1 month isn't a definitive test in terms of telling us how quickly it will come back or whether it will come back at all. So and extremely low covers a range of conditions. So there are some people who wind up on prednisone or other cortisol-like agents indefinitely because either from I wouldn't say natural cause, some disease process that shuts down their adrenal gland, or much more rarely shuts down the hypothalamus, parts of the hypothalamus, or parts of the pituitary. So Addison's disease is an insufficiency of cortisol, and it if untreated, it can be fatal. So cortisol is essential for life, but it can be well managed by giving external drugs. Now that would be a bad outcome. So again, I think without knowing more of the details, it's still within the likelihood in general that someone's adrenal glands would come back even a month more longer than a month after being suppressed by prednisone. So sure. So Dylan's asking a follow-up question. So is administration of ketamine and memantine generally safe? So both of these drugs we think are NMDA blockers. Memantine, I would say, has an extensive track record of being safe. Ketamine can be powerfully effective for depression. There's no and quickly effective. It can specifically help with suicidal ideation. Ketamine has a considerably greater risk for addiction issues than memantine does. Whether some of that's related to mode of administration or IV or nasal spray. There are also a number of cases of people who have abrupt withdrawal, severe depression, suicidality after stopping ketamine. So it's not just that it might have addictive properties, we may be making some people addicted to it. Ketamine clearly has a potential for inducing psychotic-like states of derealization, hallucinations. Memantine, at least in available doses, that's not a perceivable risk. I mean, it's part of why with ketamine and esketamine that the requirement is that someone administer it in a situation where the patient can be observed for the hour or two afterwards. And with ketamine, there's also, we've known from the beginning, some incidence of bladder and/or urinary tract inflammation and problems, some of which can be quite serious over time and probably increase risk with lifetime exposure. So many people use ketamine safely and effectively, but ketamine does have many more serious risks built into it than memantine does. So, so acetylcholine asks, I heard that if a neuron releases adrenaline and acetylcholine at the same time, this stimulates the creation of new synapses. Is this true? So one is it's probably more the situation of, I mean, each neuron in our body is receiving input from hundreds, if not thousands, of other neurons. This is a gross simplification, but in general, mammals and humans, each neuron generally is using just or delivering, releasing just one neurotransmitter. That's an oversimplification, but I'll leave it at that. So it's the receiving neuron that is probably getting hits of adrenaline and acetylcholine, and that may facilitate synapse creation more effectively than just one of those together. I- I'd say yes, it's fair to say there's some evidence to support that. So Alexei asks, is 120 milligrams Elvance or Vyvanse a day too much? I can sleep all right. So great, Max is predicting what I was going to answer because this comes up fairly often. It's a good question, but it's on people's minds. My strong approach to dosing is that we should be treating patients, and that means we should be paying attention to what are the benefits, what are the adverse effects, and the number of milligrams is at best a very loose, crude guideline as to what we should be doing. So if at 120 milligrams of Vyvanse, you're getting more benefit for ADHD symptoms than you did at 100, and you're not showing any problems with difficulty sleeping, feeling too revved up, overstimulated, too emotionally labile, too aggressive, appetite suppression, any of the other side effects, then it's probably okay. Now, is there some weak data that suggests the higher dose over time may be related to higher rates of bad effects, either cardiovascular or psychosis? I'd say there is a general, yes, there's a little bit of evidence. What that doesn't tell us is what the blood levels of those, I mean, presumably people who are taking a bigger dose um, have differences in how they're processing the drug, and their blood levels are probably in the quote normal range. And yeah, so and the absolute risk of either psychosis or cardiovascular effects is quite tiny. So that's an absolute risk in terms of a relative risk. So even if a study showed you have 2 to 5 times the rate of developing psychosis on a high dose amphetamine than on a low dose amphetamine, the rate of developing psychosis is still way lower than 1 out of 500. So Dylan asks, do I agree that MAOAs are more effective for atypical depression than they are for melancholic depression? Apparently, atypical depression often doesn't respond to SSRIs and such. Um, so again, it's sort of a Psych 101 textbook claim, and there is a little data that can be interpreted to support the view that MAOs work better for atypical depression. Um, but there are many people with atypical depressions who do respond to SSRIs or to Wellbutrin. So I'm not sure that it is a clear and distinctive benefit as widely claimed, and there are numerous studies failing to find preferential benefit. So, um, yeah, and again, one is many of the comparisons are based on general effect sizes rather than a head-to-head comparison. And if you're doing a head-to-head comparison, it's really easy to get skewed results depending on the dosing. So, are you giving an unfairly low or high dosing to your competitor? Do you either intentionally or not skew the results? So KVV asks, how do I get tested for ADHD? So I would back away from that. You probably, if the question is, do I have ADHD? You don't want to test for ADHD. You want an evaluation for ADHD. That might sound like semantics, but the implication for test is that we have a test, either a blood test, a brain scan test, a set of neuropsychological questions that, when administered, will say, yes, this person has ADHD or not. So I do have a video on testing in ADHD. Testing, even the neuropsychological testing, at best can be supportive of a diagnosis. They may be helpful in sorting out or differentiating ADHD from something else. But all of the organizations, the psychiatric associations, the pediatric associations, the ADHD specialty organizations say the gold standard evaluation for ADHD is a clinical evaluation where someone sits down and asks you a bunch of questions by someone who is familiar with ADHD. So most university academic centers should, with a psychiatry department, um, should have people experienced with ADHD. In the US, CHAD, Children and Adults with ADHD, is a patient and family centered ADHD support group, and they should have support system network, and they should have referrals to local providers who have skill and ability in diagnosing ADHD. So a word more about checklists. And Max did provide the list for the testing. I mean, part of the downfall of most of our checklists are screening tools to identify who may benefit from a more thorough evaluation. But part of the difficulty with ADHD is many of the executive function problems, whether it's distractibility, whether it's sustaining attention, whether it's reducing, inhibiting impulses, whether it's fidgeting. So many of those symptoms can arise from depression, from anxiety, from PTSD, from other conditions. So just checking it off on a symptom checklist doesn't tell you what age this developed at, what are the factors that make it better, what are the factors, if any, that make it worse, what are the triggers for provoking it, what are the symptoms that occur together or occur in absence. Okay, so Dylan's asking a different question than what I answered. So, and the question is it okay to take memantine and ketamine together? And so getting back to ketamine and whether it's, I mean, there are many people, and I'd say the most commonly accepted view I see online is that ketamine is primarily an MDA agent. Um, but there's some good evidence from Stanford and elsewhere that ketamine is also involved in opioid receptors and sigmoid receptors, and particularly the opioid receptors seem, at least in some studies, that blocking opioid systems blocks some of the antidepressant effect. So it's clear that these two drugs are not simply doing the same thing. So to that extent, there may be benefits to administering them together. I mean, they should potentiate or at least add to each other's NMDA blocking effects. So again, if, approach it cautiously and see what you're getting would be the general recommendations there. So thanks, Acetylcholine, for the feedback. Again, I encourage people to share this channel and this Q&A hour with others if you're finding it useful. Um, so Dylan, no, someone is having urinary issues. I thought it was due to atomoxetine. After a month, they got diagnosed with a bladder infection. So yeah, lots of conditions in our bodily systems can be created by drugs, can be created by infections and other processes, and the two can occur together and and influence each other. So having a bladder infection probably also does make people more sensitive to urinary tract issues with atomoxetine. There it's mostly sphincter contraction, which can affect the ability to flow or not flow. And probably the presence of atomoxetine may predispose some people to having bladder infections. So there's two-way complicated interactions there. So the good thing is it sounds like it's resolved and you know what did it. So John Bracken's admiring the wood paneling. I'd say the downside of the wood paneling is I'm in rural Hawaii and this is knotty pine, so it was not a locally sourced wood. But yeah, it looks nice. And the strange impression is the building I'm in is, this is maybe oversharing, is a concrete and glass structure. I've never done this live before and I may knock something over. I'm just going to show you. There's a big glass wall. That's our water containment system, but there's part of the concrete. So I'm in a modern concrete and glass building, but it looks very wooded and cozy here. So that came through. So Max has some links and then asks, at what point do you consider depression to be resistant? Once you've made that determination, how does it change your treatment plan? So it's an interesting question and concept. And so there are a variety of different definitions of treatment resistant. Usually the least restrictive is having tried at least 2 therapeutic trials of at least 6 to 8 weeks of at least 2 different acting or 2 different antidepressants. Others are more rigorous, include 3 or 4, and include that they have to be from different pharmacologic classes or modes of action. There's also the question of whether partial responses and how much of a partial response is. So most people who are, it's rare for people to have absolutely no improvement or reduction in any of their symptoms. But many people have only minor or insignificant improvement in symptoms. So secondly is many of the people I've seen over the years, even though I haven't been taking any new patients for the last 3 years now, came to me because they had already not gotten satisfactory treatment elsewhere. So, what's interesting as I'm trying to answer the question is I'm familiar with the concept, but I never in my head said, oh, this is a person who's treatment resistant. I always framed it as this person hasn't responded to what's been tried before. So my framework doesn't actually, my framework is always what have you tried before and what's worked and what's worked to what extent and what worked and had what side effects and what didn't seem to work at all. And what are our other options that either combine any aspect of what might have partially worked and avoided the downside, and what can be added to it or not. Um, so I don't know if that answers the question at all, but that's my starting point, and I'm welcome to follow up on that. Um, so the next question is on centanafidine. So I do have a video on centanafidine. So it is a triple reuptake inhibitor. So thanks, Max has already provided the link to that. Great. Max is always on top of things. Um, so it has not yet been released for ADHD. It's a triple, so serotonin, norepinephrine, and dopamine reuptake inhibitor, not in that order. Um, I mean, fairly robust on all of those, but serotonin, I think, is the weakest of the three. There's fairly extensive now. There's certainly more data than I presented in that video, which is a few years old. Evidence that it's helpful for ADHD. It's helpful for sort of the mainstream attention impulsivity ADHD symptoms. There's some posters at a recent meeting showing it can also be effective for emotional dysregulation or emotional aspects of ADHD. Um, Whether it's more beneficial than duloxetine or a dual reacting agent or a combining Wellbutrin and an SSRI, um, who knows? So I think it will be a useful addition, and it is under active review for approval for ADHD, but not yet released as of early March 2026. And so far, as long as I'm aware of, or the studies I've looked at, there's nothing in the side effects that jump out as weird or strange beyond what you would expect with some amount of SNR, serotonin, norepinephrine, and dopamine reuptake. Of note, the dual acting and now the triple acting agents tend to have substantially fewer sexual side effects than the pure SSRIs do, which are one of the most common barriers to using SSRIs, and also substantially less emotional flattening or blunting. Um, I mean, it's a curious phenomena that by messing with more systems, we often have medications that actually have fewer side effect problems. Excuse me. So, uh, Divi Amaranth said had ADHD and was bullied in childhood by classmates and my father. Experienced lots of stress and has developed insulin resistance, fatty liver, and hypertension. So I'm sorry to hear that. I hope having a diagnosis has led to some, both one, destigmatization of your condition, and two, greater functioning and or decreased in stress. But it highlights that there are lots of mind-body interactions and correlations between conditions that seem to have at least some inflammatory and or autoimmune component, like hypertension often does, insulin resistance often does, fatty liver often does. Um, so bodies and the brain is part of the body and is affected by and can affect it. So good question. So Max is asking, I've often heard that first line, second line treatments? Are the order of lines of treatment well established? And for example, what are the different lines of treatment for depression? So there are a number of organizations. The one I'm most familiar with is the American Psychiatric Association has offered treatment guidelines on depression, on borderline personality disorder, on ADHD, and usually those outline the approaches, best approaches for diagnosing the condition and for treating the condition. The APA guidelines tend to categorize these are the treatments which have good, robust evidence and are effective, and these are the treatments which have either less evidence or have more evidence of side effects or adverse conditions, and or if there's aspects like atypical melancholic or atypical versus melancholic depression, if there's differences there that respond better or worse. So it's usually not, this is the first drug, this is the second drug you should go to. It's more, there are several first round choices that are all reasonable. And then if those don't work, these are things to add on or move on to. Um, so, for example, with ADHD, I mean, we know in terms of efficacy, in terms of biggest impact on symptoms, greatest percentage of patients, the stimulants, particularly amphetamines, are most likely to be effective. However, they have higher side effect risks than some of the other options. So again, so we can come up with generalizable what are recommended, but when I'm working with the person, it's always weighing what are the side effects and other conditions they have already that they are, what are the side effects they want to avoid most? What are they most scared of? What would be most um, posing difficulties in their life? What are their target symptoms? So rather than a rigid sort of hierarchy or rigid list, I think that our first line, second line are more general categories, is how I view it. And maybe we will have much better algorithms as we compile more data or as the data that's already sitting there gets sifted through by AI bots. Dylan asks, do you think there'll ever be an effective medication for autism? Do you see autism as one condition or multiple separate conditions, which all fall under the umbrella label autism? Um, so I talked about it, I'm forgetting in what context. There was a interesting study just a few years ago. So many people object to holding in Asperger's and higher functioning autism with the rest of the autism spectrum. And some of the genetic evidence there is that there are more than 30 different genetic clusters or loci associated with autism, all of which were found in the Asperger's group as well, but there were 3 or 4 separate genetic loci or areas of interest unique to Asperger's that weren't found in other forms of it. So I think there's some usefulness to a concept, but there are clearly subgroups or clusters within that, and with clearly at least some level of different biology. And the talk I'm getting ready for and dragging my feet on, and it should have been out a week ago, was on the new changes to the DSM that they're not, these are proposed changes, but the attempt there is to incorporate much more of the research domain criteria and biomarkers. Even though we don't have specific tests and markers, we are moving more towards identifying some of the circuitry that are important and maybe for helpful for identifying subgroups of people with depression or subgroups of people with ADHD or subgroups of schizophrenia, to allow, again, more detailed prediction of how this individual's course may unfold and what treatments may be particularly effective. we still have a long way to go, but I think there's something real there. So do I think there'll be an effective medication for autism? So I guess one question there is, does effective mean better treat the symptoms and improve functioning? I think that's quite likely, even though nothing has strongly jumped out yet. I mean, there's dozens of things that in tiny studies indicate helpfulness, and in bigger studies have not panned out as useful. Whether that's because we identified a small subgroup of people, particularly a good match, or whether it was just a small study size and placebo and other effects fed in terms of, do I think we will find a medication that is completely preventative or completely obliterates all symptoms? I think probably less likely, at least in my lifetime. DIV is 20 now, can't process logics, have lots of problems in maths, coding, and memorizing. I used to study for 15 to 16 hours a day. We can't memorize and poor academics. So I do mild autism and dyslexia with strong ADHD, inattentive, methylphenidate, bupropion, buspirone. I mean, you've mentioned the medication aspects, and again, um, what I'd say with medication is dosages are interesting, but effects on the person are more pertinent. So these are all within a normal range. I would think experimenting with going higher with any of them if you feel like they're suboptimal. And the other big effect is, are there strategies and executive skills, cognitive skills that you can learn in terms of helping you? I mean, for many people there with ADHD or autism spectrum, there are. And sort of the third aspect is, are there ways to control or restrict distractions in your environment? Making sure you're getting good sleep, other factors that will help optimize your brain performance. Are you getting enough exercise? Outside is expressing appreciation. You're welcome. And thoughts on Dr. Russell Barkley. So thanks, Max, again, right on top of things way before I got to it. So I do have a video on Dr. Barkley. So he's made tremendous contributions in terms of our understanding ADHD, understanding variants or connected syndromes like cognitive dissociative syndrome, or what used to be called slow cognitive tempo. He's a rigorous researcher. He's a careful thinker. Um, he's certainly articulate, and there are some people who his style can be a little more abrasive than mine tends to be, who don't like him for that reason. But I think he has made incredible contributions. He's extremely bright and thoughtful and caring person. So there, that's probably all. I've only met him, talked to him very briefly, asking a question once. I've been to a few of his lectures in person. Mm. So one last question, I guess, and then I'll shut down. And again, for the next 3 weeks before European people catch up with us, we'll be out of sync from our regular time, but I'm going to stick with mainland US time. So Dylan asks, are adult autism assessors effective at differentiating autism from other conditions? He was diagnosed with ADHD as a teen, but now as adult, therapists have suggested that I'm on the spectrum. And as a follow-up question, can trauma PTSD worsen autism and or make it more apparent? So I do have a video on autism and ADHD, and what I have seen clinically is lots of that autism has become the fad diagnosis. I do believe it really exists as a condition. I do believe it occurs commonly with ADHD, but I've also seen people whose symptoms to me were entirely explained by ADHD who were told that this and this was autism, and what they were being told was purely ADHD symptoms. So a careful neuropsychological assessment should be helpful in teasing out. But what I would say my experience is, even though these tests are supposedly objective, you supposedly get the same score. One is that there are differences in people, how they administer them. And two, there are clearly big differences in how people interpret them. And there are assessors who everyone who goes there will get an assessment that, yes, you're somewhere on the autism spectrum. And there are others who, regardless of their symptoms, will be told, no, there's no autism here. And there's hopefully a bigger pool of careful assessors whose assessment is more closely linked to reality there. Um, and so trauma can worsen almost anything that's going on with the brain. Yeah. So, this really will be the last question. So, again, the focus on ADHD is about dysregulation of dopamine and norepinephrine in prefrontal cortex specifically. Can we deal with other neurotransmitters in order to boost cognitive abilities process, such as acetylcholine? So I do have videos on acetylcholine. I believe I have on glutamate. Those are the two at the top of the list that are clearly have a role in ADHD treatment. Um, so, yeah, I mean, we come up with simplistic models, and I think we need to do that to understand the brain. But remember, they're simplistic models, and that all of these systems are modulating and affecting each other. I throw serotonin in there. So, although SSRIs don't seem to be helpful with core ADHD symptoms, there are clearly serotonergic involvement in ADHD as well. And hopefully, we will be more skilled at using the range of things that help. So stay healthy, stay happy. I'm glad you're here and listening and asking great questions. And I'll be back next week.